So, starting back again after the break. So, Bismillah ar-Rahman ar-Rahim. I hope you all know me. So, my name is Dr. Nasar Khan, and I'll be presenting again on bipolar affective disorder. I was going through my last presentation after I made this presentation, and I felt that there are a few things that probably still needs to be clarified. So I made this presentation before I went back and saw that I already presented on bipolar disorder. So maybe this one is a little bit different than the previous one. And I hope you will be able to understand some of the more dynamics in the bipolar disorders than you had the insight about it earlier. So we will be talking about the psychopathology, pathophysiology, and the treatment options in the bipolar disorders. Briefly, I will try to cover up the presentation in next 45 minutes or so, but if you have any questions, we can extend it as your interest would be. So any question, you can type on the chat box, or you can communicate to me directly, and I can stop and then explain it further. So let's start. So ये एक छोटा सा अगेन गजल टाइप चीज थी जो मुझे नजर आई, तो इसमें कुछ कॉन्सेप्ट मुझे अच्छा लगा, सो आई थॉट दैट आई शुड गो फॉर इट। मुझे जिंदगी में कदम कदम तेरी रजा की तलाश है, तेरे इश्क में अल्लाह मुझे इंतहा की तलाश है। मैं गुनाह हूँ, मैं हूँ डूबा हुआ, मैं जमी हूँ पर हूँ गिरा हुआ, जो मुझे गुनाहों से बरी करे, मुझे उस दुआ की तलाश है। मैंने जो किया वो बुरा किया, मैंने खुद को खुद ही तबाह किया, जो तुझे पसंद हो ए अल्लाह, मुझे उस अदा की तलाश है। Throughout our life, we are seeking the best for us, and this is what we all probably try to get. But during the process of achieving the best, we do have some ifs and buts. In bipolar disorder people, if I talk specifically about this, I'll be more pragmatic about the approach. So I will say that sometimes when you are in a hypomanic or a manic state, you get some answers that probably nobody would be able to get them. And when you are depressed, you lose all the hopes. It's a very tricky illness. And because of its tricky nature, remitting and relapsing situation, you see a patient, he comes to you with the depressive symptoms, you start evaluating, and then you realize that, and you give antidepressants, you take the history, you don't have any account, but suddenly after a few months' time, the patient comes back to you with a switch. So he's into a hypomanic phase or a manic phase. And then you realize that probably this was not only depression, this is more to it, and maybe he's the bipolar. If there are one or two episodes in the lifespan of a person of a manic, hypomanic, or a depressive state, then things are usually clear to most of the psychiatrists when they are seeing him, because there is definitely a chain of events associated, so the diagnosis is more firm. But if the person is coming first time to you with no history, then sometimes it's tricky to diagnose a person as bipolar in the first setting. So in psychiatry, we unfortunately have to rely on multiple things, specifically on the follow-up situations as well. If you lose your patient, if he goes to somewhere else, maybe the next psychiatrist would be having the same difficulty. But of course, our patients in Pakistan keep on roaming around here and there. In exams, when we get the patients in exam situation, this is a common presentation. In my FCPS examination, I had a bipolar patient, and I diagnosed him to be bipolar. At that time, he was in remission. So there were no active symptoms. So everything was associated with the background information that I got from him. So it was not at that point in time that I was able to assess the depression or hypomania or mania. But when he started talking to me, he described to me what was happening in his life for past 2 years' time, and I realized it was bipolar. I passed that exam on the basis of my assessment when I was able to say that currently he is in remission, but the history dates back to this much time, these many episodes, this were the treatment strategies, and this is what is the current situation. I got through. So your grip of the situation, understanding the patient, and then proceeding with it is more important than anything else. So try to assess the patient completely in all parameters before making the treatment strategy. The treatment is successful only if you make an appropriate diagnosis. And for diagnosing bipolar disorder, sometimes it's very tricky. So let's talk about the psychopathology and the treatment of bipolar disorders. Bipolar disorders has traditionally been viewed as purely biological based group of disorders, but bipolar disorder episodes are best understood within a biopsychosocial framework. That is, recurrence of mania or depression are a result of the mutual influential interactions between genes, neural pathways, and socio-environmental influences. So people do get these episodes with the precipitants in the home environment, work environment, or day-to-day life events. So a
सर
person may come to you.
सॉरी,
Yeah.
आप एक बार स्लाइड्स को रीशेयर कर सकते हैं?
दोबारा से reshare कर. No problem. I will do that. Okay, let's do that again. Stop sharing and then start sharing again. Okay. Oops. Stop sharing. Confirm. Stop sharing and start sharing. Start sharing again. Okay. Can you see it now?
I
Okay.
can.
Okay. So the interactions of biological and the psychosocial risk factors in the course of the illness, the current pharmacological and psychological treatments are then reviewed. This is tricky. As I said to you, the patient may be coming to you with grief, and you will find all the symptoms of grief. And when you start treating grief over the period of time, you realize that this person is not actually having grief. He is having bipolar disorder, which is precipitated by the grief. So sometimes this is tricky, and we fail to understand in the initial process of assessment what actually is happening to the patient. And that this is what is we want to talk about today. And this is what I want to talk about it today. So, oh, you people are still not able to see it? Okay, let me, okay. Can you see it now?
Sir, I see only a white colored screen. That's it.
Oops.
I don't know. Usually ऐसा नहीं होता. Usually I see the slides.
Usually, yes. Okay, let's try this. Okay, can you see it now?
Yes. अब आ रही है नजर.
Okay, so now you can see it, right?
Yes.
Okay, so there are messages probably related to the screen sharing. Okay, Naima still feels that we are not able to share the
No, sir.
screen.
Now we can. हाँ, अब नजर आ रहा है. पहले वो सिर्फ एक plain white screen आ रही थी actually. अब ठीक
Okay,
है.
sorry about that. So we will continue with the same process. Okay, moving forward. Bipolar 2, moving forward, definitions. So there are usually two kind of bipolar disorders that you all know, bipolar 1 and bipolar 2. But when I'll be going through these slides, I would be able to tell you more discreetly that there are other forms of the bipolar disorders as well. Some of them are still in research process. Some people agree with it, some people don't agree with it, but there have been bipolar disorders. Some of the major people who describe bipolar disorder, the researchers, they say that the bipolar disorder exists in multiple forms, from bipolar 1 to bipolar 7. 1, 2, 3, 4, 5, 6, 7. Now, they have their own criteria of doing that. I don't know how much it is, because in the textbook, it is still bipolar 1, bipolar 2. Some cases, in some of the books, bipolar 3. But again, researchers in this area say that they have seen bipolar 4, 5, 6, and 7 as well. Those criteria, maybe we'll be able to touch them briefly as well. When we talk about bipolar 1 disorder, which was formerly named as manic depressive illness, it is defined at least one lifetime manic or mixed episode. Mixed episode means manic symptoms, hypomanic symptoms, or depressive symptoms together. So one definite manic, hypomanic symptom, the bipolar 1. The diagnostic criteria specify that mania must last at least 1 week or require hospitalization. So either you are not able to assess the mania, or the mania was again to an extent that it lasted for a week or 10 days. And then you say, okay, fine. There were 10 days in this person's life where he was very hyper, agitated, having flight of ideas, delusions. So even that lasted for a week. Now there are no symptoms for it, but he will still be labeled as bipolar 1. Now, manic symptoms include irritability, euphoria, along with the symptoms such as decreased need for sleep, grandiose ideas, impulsive behaviors, increased talkativeness, racing thoughts, flight of ideas, increased activity, and distractibility. Mixed episodes include manic symptoms and simultaneously depressive symptoms lasting for at least 1 week. Now, if somebody asks me that, have you ever been in a state of mind where you were having racing thoughts, increased talkativeness, or you were very impulsive, I will start looking at my thing and then I will say, maybe there was a week where I was like that. This never means that we are able to give a diagnosis on a concrete basis. This means that we are having a question mark. This person now presenting with depressive symptoms says that there was some life events where he was hyper. He was having increased activity. He was working more. He was not sleeping. And probably again, in everybody's life, there is a time period when you want to sleep less, you want to work more, you want to complete the task. Your mind is racing because you have to do so many things. So that is again tricky. How much evident it is for me to label that person as bipolar disorder, I don't know. So psychiatry is unfortunately fluent, especially when it comes to retrospective recall. Most, but certainly not all people with bipolar disorder 1 experience periods of depression. So those 10 days were the good days. And afterwards, there were months and months where I was sad, slow, depressed, guilty, blah, blah, blah. You all know those symptoms as well. We'll talk about them more. So sometimes it is very tricky to say it with certainty that this person is having bipolar disorder 1. Bipolar 2 is defined by at least one lifetime hypomanic episode along with at least one episode of major depression. So major depression is definitely diagnosed. There is no doubt about it. The person is gloomy, sad, bedridden, most probably doing nothing, away from work, and people pick him up and bring to the doctor and say that, oh, something has happened to this man, he's not getting up. And we say, okay, fine, this is depressive disorder. But usually hypomanic symptoms, like if I am wearing a flashy cloth, purple colored suit, in attending a conference, meeting everyone, greeting everyone, and this lasted for a week or so, nobody will probably notice it. They will say that this is odd, why he's dressed up so much. But generally speaking, it is not considered to be abnormal, to be a little bit hyper, a little bit again on the other side. So sometimes that manic or hypomanic phase lasting for a week is missed in the history. But if you are vigilant, if you're a good psychiatrist, if you know that these things are important in assessment, you'll be able to find out. As I gave you my own example, but that in exam situation, I got a bipolar patient. He was having bipolar 1 disorder. He had a manic episode, but at that time, he was in remission. So it was all based on retrospective recall and assessment. And when it was based on retrospective assessment and evaluation, my sharpness of assessing the person for manic, hypomanic states in the past and depressive episodes will lead me to an appropriate diagnosis of bipolar 1 or bipolar 2. Hypomania is characterized by the same symptoms as mania, but lasts for a shorter intervals, 4 or more days, and although noticeable to others, is not associated with functional impairment, which is again a tricky situation unless or until you are very much vigilant in assessing the patient. Episodes of major depression are defined by 2 or more weeks of intense sadness or loss of interest, accompanied by symptoms such as fatigue, insomnia, psychomotor agitation or retardation, weight gain or weight loss, cognitive dysfunction, feelings of worthlessness, and suicidal ideation or attempts. Converting from bipolar 2 to bipolar 1 is rare. So again, I will focus. Once you say that this person is suffering from bipolar 2, he won't go into bipolar 1, usually not go. So rare, but it's possible. So you have to be careful about that statement as well. The third category in bipolar disorders is cyclothymia and NOS. NOS is the term which is used, not otherwise specified. This term was used in DSM-4 and DSM-4-TR. DSM-5 also mentions it, but now the focus is more on other main categories and less on the NOS categories. Sometimes for legal purposes, we may use NOS when we are giving medication which can be certifiable, the treatment for psychosis, we say NOS. But usually, it's difficult sometimes to assess. So you have to be vigilant. It's all dependent on your retrospective assessment of the events which happens in patient's life, which is unfortunately tricky. So even if you ask me, talking about, say, 10 years ago, I had an episode where I attended 5 marriages in a week. I was dressing up every day. I was very active, talkative, nicely, again, communicative, and I never lost any functional capabilities. I was working as well. Will I call it hypomania? Could be. It all is dependent on how you assess them. Cyclothymia is characterized by 2 or more years of alterations between hypomanic and depressive symptoms that do not meet the DSM-4 or 5 criteria for MDD or hypomania. So there is fluctuation, slow, fast, slow, fast, slow, fast, but they are not, again, manic episode or hypomanic episode, and they are not actually depressive episodes or major depressive episodes, but they do have fluctuations. Again, the assessment demands that you have to be careful and vigilant. Bipolar disorders not otherwise specified is usually reserved for patients whose disorders meets the minimum number of required symptoms, but not the duration requirements for full manic, which is 1 week, hypomanic, which is 4 days, mixed or depressive episodes, which is 2 weeks. So you see, now there is a range and complication. So in exam, when you are writing these things or there is a question about the history and there is a format given about the history and these things are mentioned, you have to be careful about the days as well. You have to look carefully about the days. What are the number of the days of the illness mentioned in the history provided to you? So if it is a week of manic symptoms or 4 days of manic symptoms, hypomanic symptoms, or 2 weeks of depressive symptoms, then of course they are bipolar disorder 1 or 2. But if not, still the possibility is that he is having bipolar disorder, but it is cyclothymia or bipolar disorders NOS. So again, you have to be careful. This is unfortunately crucial, critical, and complicated. So this is the reason why I'm focusing more on it, and you have to understand this more clearly. If there is any questions, please stop me, or otherwise I will continue. Okay, ये छोटी सी गजल, तेरा हिजर मेरा नसीब है, तेरा गम ही मेरी हयात है, मुझे तेरी दूरी का गम हो क्यों, तू कहीं भी हो मेरे पास है, मेरे साथ है. बाइपोलर पेशेंट. मेरे वास्ते तेरे नाम पर कोई हर्फ आए नहीं नहीं, मुझे खौफ दुनिया नहीं मगर मेरे रूबरू तेरी जात है. तेरा वस्ल ए मेरी दिल रुबा, नहीं मेरी किस्मत तो क्या हुआ, मेरी माहजबी यही कम है क्या, तेरी हसरतों का तो साथ है. तेरा इश्क मुझ पे है मेहरबान, मेरे दिल को है हासिल दो जहां, मेरी जान जान इसी बात पर, मेरी जान जाए तो बात है. So I'm willing to sacrifice everything. Now, something related to the epidemiology. Now we have to be very careful because we have described the symptom complexity in bipolar disorder. Now talk about epidemiology, we have to correlate, always correlate the presentation with epidemiology if we want to make a concrete, firm diagnosis and treatment strategy. If we won't do that, we will miss something. Like in women and men are equally likely to develop bipolar disorder 1, although women report more episodes of depression than do men, and correspondingly are more likely to meet the criteria for bipolar 2 disorders. In the National Comorbidity Survey replication, the median age of onset was 25 years. So remember, schizophrenia presents around the age of late teens, early 20s, and bipolar presents to you in mid 20s or late 20s. This is crucial. So maybe the psychotic symptoms are still there. Okay, somebody said something. Okay. So maybe the symptoms are there, but he is probably having psychotic breakdown, which could be schizophrenia in nature as well, because he is having early 20s. But if he is falling into 25 and 30, I will definitely consider more it to be a bipolar than schizophrenia. So again, correlation is important. So you people have to be careful about making correlations of the symptomatology with the epidemiology. This is a woman who is 32 years of age presenting with symptoms of, again, some loosening, some hyperactivity, some anger or agitation. Could it be bipolar or schizophrenia? If you correlate it with the epidemiology, I will say more chances of having bipolar than schizophrenia. So this is what the importance is. I hope you would be able to understand this. The onset of bipolar disorder and depression appears to be getting younger with successive birth cohorts. In the National Comorbidity Survey Replication Study, Kessler et al. In 2005, the lifetime risk for bipolar disorders 1 or 2 disorder in the youngest age cohort was 18 to 29 years, was 22 times higher than the oldest cohort over 60 years, although the role of age-related reporting biases cannot be ruled out. Now, as I mentioned, I will definitely correlate it with the symptoms correlated with the epidemiology. And if the patient is 30s, I will consider more to be bipolar. If the patient is 19, I may say that probably it's the onset of schizophrenia. So the correlation is important. And this correlation is again based on your judgment as a psychiatrist when you are assessing and evaluating these people. Comorbidity, differential diagnosis. Whenever in exam situation, people ask you references related to bipolar disorders, there are two names that you can safely say for most of the references. One is the older one, which is Kessler, 2002 to 2009, right? And the other name is Ekiskal. Ekiskal worked a lot on bipolar disorders. So anywhere you feel that you are forgetting the name of the references, think about these two names in bipolar disorder references, Kessler, Ekiskal. If you read through them, Kessler or Ekiskal studies related to bipolar disorders, you will feel that they have talked about every dimension of bipolar disorders. Their whole life was spent on assessing the bipolar disorders. So mania, hypomania, and ADHD. Now there is a third component to it, which we never focus actually. This patient is having hypomanic symptoms or depressive symptoms or bipolar symptoms along with attention deficit hyperkinetic disorder. And they are commonly found together, followed by oppositional defiance disorder, agoraphobia, panic disorder, generalized anxiety disorder, and substance abuse. An epidemiological study using DSM-3, old study, estimated that 61% of bipolar disorder patients had lifetime alcohol or substance abuse problems. So most of the people who are coming with the bipolar disorders, if you ask them, majority of them will say that they are either consuming alcohol or some kind of substances to keep them calmer. And in Pakistan, benzodiazepine is unfortunately a very common thing that is used for this purpose. We may not be able to find alcohol abuse or any other abuse of the drugs, but the benzodiazepine is common. So you can always go for it and see it. It's tricky, but it's definitely there. Approximately 20% of the patients who enter outpatient treatment have had 4 or more episodes, rapid cycling, within the prior year. Over 1 year period, 37% of bipolar disorder 1 patients had recurrence of mania or depression. Over 2 years, 73%. Over 5 or 7 years, even when treated with pharmacotherapy, 73%. So relapses, despite giving them medications, are common. We always lose heart when we are treating bipolar disorders. This patient was stable. I stabilized him on lithium and valproate combination, and he was doing very well. And then he came back with a relapse after 4 months. Well, don't be panic. Don't be upset, because unfortunately, despite pharmacotherapy, the relapse rate is 73% in bipolar disorders, which is very high, very, very high. So again, something tricky. In a prospective study spanning near 13 years, subsyndromal symptoms, notably subsyndromal depression, were more common than fully syndromal symptoms and were present during approximately half of the week of the follow-up. In general, depressive symptoms of bipolar disorder illness persist longer than manic symptoms. This I mentioned in earlier as well, that bipolar patient spends more time in depressive episodes than in manic and hypomanic states. And I am always comfortable if my patient stays in a little bit of a hypomanic state than in a depressive state. Because if he is in a depressive state, the chances of committing suicide, losing the patients with comorbidities, physical complications, substance abuse is more than if the person is slightly on a hypomanic state. So the people who work with me or are working with me, they know that I always say that little bit of higher end on the bipolar disorder, if not completely the baseline, I will still resolve to going for it, then keeping him in a depressive state. That is miserable. That is complicated. That is problematic. And that is always problem. And then if I consider the differential diagnosis and the comorbidities, which I talked about it, ADHD, oppositional defiance, panic disorder, GAD, substance abuse, these are all the differential diagnoses. These are again more complicated, more again difficult to treat. And suicide is unfortunately, it's a never ending thing. And we are always complicated with it if the person is suicidal. I always ask my people to say and ask these questions very directly about the suicide. Don't miss it. If a psychiatrist misses the assessment of a suicide in a patient, this means, unfortunately, you are not a good psychiatrist. So ask every patient about the suicide or a death wish. Bipolar disorder is associated with higher rates of suicide than any other psychiatric disorder. Rates of completed suicide appear to be as high as 15 times the rates among the general population. It's a big number, very big number, and 4 times higher than rates among patients with recurrent depressive disorder. Risk factors for suicide include a predominantly depressed presentation, substance or abuse, being young, male, recent illness of onset, significant anxiety, impulsiveness, family history, and social isolation. These are complexities and problematic things. Psychosocial impairment and illness cost. Unfortunately, when somebody is having schizophrenia and it's a relatively older schizophrenia, we say relatively in a chronic state, we know that this person probably is not going anywhere and he probably won't be that productive as he should be. But in bipolar disorders, patients could be very productive, but unfortunately very unproductive as well, because they keep on swaying between normalcy and up and downs. So bipolar disorder is ranked as sixth cause of leading disability worldwide. A recent examination of 253 bipolar disorder 1 and 2 patients found that only 33% of the patients worked full-time and 9% worked part-time outside the home. Fully 57% reported being unable to work or working only in sheltered settings. So you just look around your setup, you will feel that if somebody is having fluctuations, they are not able to sustain their job very regularly. Absenteeism is common. Late coming is very common. They are usually late in doing the work, doing the job done. If they are not able to take the decisions they have to take, if they are not able to again procure what is required for their job to do, you will say that this person is having some problems. Assess them for bipolar disorders. Bipolar disorder is believed to be associated with elevated creativity and productivity. So when I am in a hypomanic phase, I will be very productive. I will produce results that probably nobody was able to produce in months and months. That is related to bipolar disorder, which is a good thing. And that is another thing where I feel that, okay, fine. So if he is productive, he is producing some good music, he is writing some good stuff, he is politician who is appearing to be very vigilant and aggressive and mixing with the people and doing good for the people in general, I will be definitely happier as a psychiatrist than person who is spending more time in depressed state. So there are also temperamental commonalities between bipolar disorder patients, and a highly creative person without psychiatric disorders, including openness to new experiences and novelty seeking. So the other day I was watching a YouTube and there was a man who was trying to climb on the ropes between the two highest buildings of the world. Could it be bipolar disorders? Could it be? Well, I don't know because I haven't seen that person, but I would definitely would like to assess him if I have been given a chance to do so. So you have to see this aspect as well. Developmental perspectives on bipolar disorder. Sorry, D is missing. In community samples, between 0% and 2% of adolescents meet diagnostic criteria for bipolar 1. So the prevalence of bipolar disorders is 1% in general population, up to 2%. Depression is more common than, again, mania and hypomania. As one would expect, prevalence estimates of bipolar disorder, spectrum disorders are higher in pediatric psychiatric facilities with an estimate from 6 to 7%. Usually when the child comes in to us, we assess them. He is an hyper kind of a child. We may make the diagnosis of ADHD and treat it, but we never see the bipolarity. I still remember one of my patients in Pakistan in Services Hospital. That young boy, he presented to us in our outpatient department with lots of hyperactivity and lots of aggression and violence. He was at that time 80 years old. People were reluctant to give him the medications, antipsychotics especially. I assessed him. I had hospitalized him. He stabilized on 7.5 milligrams of haloperidol. The symptoms were okay. I continued to follow him up over the period of years. And there were fluctuations. There were depressive symptoms as well. And then we started him on valproate and he stabilized. I kept on seeing him till the time he was in grade 11, which was good. So at least 7 years I saw him. Every 2 to 3 months he used to come. And he used to come and see me because of one reason. Every time he used to come and see me, I was giving him something that could interest him. Sometimes a bag of chips, sometimes a lollipop. And if I had nothing, I used to ask him, what do you want to get? And he said, okay, I need chocolate. And I used to give him 50 rupees. And he was so happy with it. He kept on having a follow-up, regular follow-up for 7 years. So sometimes these small things can make your patients come and have a regular follow-up and complying to the treatment as well. Well, there are lots of ethical issues associated with it, but I still feel in the best interest of the patient, we can talk about those issues and, of course, rectify or correct them if needed. Okay. Bob Gulisha, ਅਸੀਂ ਨਾਜ਼ੁਕ ਦਿਲ ਦੇ ਲੋਕ ਹਾਂ ਸਾਡਾ ਦਿਲ ਨਾ ਯਾਰ ਦੁਖਾਇਆ ਕਰ ਨਾ ਝੂਠੇ ਵਾਅਦੇ ਕੀਤਾ ਕਰ ਨਾ ਝੂਠੀ ਕਸਮਾਂ ਖਾਇਆ ਕਰ ਤੈਨੂੰ ਕਿੰਨੀ ਵਾਰੀ ਮੈਂ ਆਖਿਆ ਏ ਮੈਨੂੰ ਵਲਵਲ ਨਾ ਅਜ਼ਮਾਇਆ ਕਰ ਤੇਰੀ ਯਾਦ ਦੇ ਵਿੱਚ ਮੈਂ ਮਰ ਜਾਸਾਂ ਮੈਨੂੰ ਇੰਨਾ ਯਾਦ ਨਾ ਆਇਆ ਕਰ. And then unfortunately I have to quote my past patients to make you people understand. Etiology. Any questions so far? Nope. All good? Should I continue? Okay, let's move forward. Etiology of bipolar disorders, genetic studies. We all know, again, it's a common theme that there is genetic vulnerability to bipolar disorders and schizophrenia. It is proven with the studies. Strong family history of bipolar disorder lead to, again, more chances of getting into the subsequent generation. And people have found a number of genes associated with bipolar disorder. One of the gene is 18p11. Another gene is 13q32. If you will be able to remember these two genes, they are sufficient. One gene, 18p11. Second gene, 13q32. 13q32, 18p11. Two of the genes responsible mostly in bipolar disorders. Some 22q11, 13q32 may be associated with schizophrenia as well, but mostly if you mention these two genes, 18p11 and 13q32, it will be sufficient in the exam situation. Neurotransmitter dysregulation, we all know again, norepinephrine, dopamine, and serotonin plays the part. In functional studies, bipolar disorder 1 disorder is associated with elevated activity in amygdala, a key brain structure involved in identifying the significance of emotionally relevant stimuli of both negative and positive valence. PET studies and functional MRI studies of activity during cognitive or emotional tasks have each shown a pattern of amygdala hyperactivity among people with bipolar disorder 1. So, genes, what were the names of the genes? 18p11 and 13q32. What is the, again, pathophysiology as far as the brain structure is concerned? Amygdala. Amygdala and hippocampus. Neurotransmitters, norepinephrine, dopamine, and serotonin. So 3 questions attempted. People with bipolar disorder also demonstrate diminished activity of hippocampus and free frontal cortex or anterior cingulate gyrus. That is important. Psychosocial predictors, criticism, hostility, guilt induction, emotional over-involvement, negativism, they all lead to complications, just like any other psychiatric morbidity. Okay, I just have to look at this number of the slides that I have crossed. So we are almost done, which is good. So I hope I won't take much of your time. So psychosocial predictors of mania. So psychosocial, psychological, again, domain explaining bipolar disorders. Manic defense model. If you talk about manic defense model, psychodynamic models have long conceptualized mania as a defense against loss experiences and painful awarenesses. So when we say that this person is suffering from bipolar disorder, what is your psychological formulation or psychosocial formulation? You will always mention it is a defense against loss experiences as far as the mania is concerned. 6 out of the 8 available cross-sectional studies show negative life events are no more common before than after manic episodes. Second is goal dysregulation. So first is manic defense model and the second is goal dysregulation. The goal dysregulation model suggests that mania may result from excess goal engagement secondary to increased sensitivity of dopaminergic reward pathways. So I need more and more and more and more because I'm not getting satisfied with what I'm having, right? Money, more and more. Power, more and more. There is another incident that I definitely would like to quote you here. One day I was called by the principal that tomorrow morning we are expecting the CM to come to Services Hospital. So we should all be there and we all have to report there at 8:30 a.m. in the morning in front of the emergency. So all the professors, head of the departments, they gathered at 8:30 at that time. I always used to ask myself, why people want to be a politician? And that day I realized that this is the reason why people want to be a politician and in power. That is the power. Nobody, not even the filthy rich person in Lahore, can have that thing which a person with power in politics can have. So we were there at 8:30. At 8:37, the principal said the CM would be here in 5 to 7 minutes. I saw one vehicle coming in, and there were lots of people in it in a simple dress. They just disseminated and just mixed up in the other people. Then another vehicle came in after 30 seconds, again 7, 10 people mixing in the people. These were all security people in the common dresses, right? The third vehicle came in again. So there were about 30 people among us who were the security people. They were not actually just the people who were standing there. And then at 8, just in 3, 4 minutes time, the principal said the CM just left the house. Now the CM house was approximately 7 kilometers away from Services Hospital, 7 kilometers. And in Lahore, if you have to cover 7 kilometers, it will take you at least 25 to 30 minutes. But CM was there in just 2.5 minutes from his house to Services Hospital in 2.5 minutes. And in those 2.5 minutes, why? All the traffic stopped, all the guards, again, gates closed. So the car leaves the CM house, reaches the Services Hospital at the speed of probably 100 kilometers an hour, and in 7 minutes, 2.5 minutes, they were there. Now that is the strength, that is the power which we feel in politics can give you. No rich man, even if he is having 3 cars, 2 front, 2 at the back, and he is sitting in Rolls Royce, can travel this much fast on the roads of Lahore. So this is what is actually the reward pathway, the dopaminergic reward pathway. I hope I'm explaining it correctly. Sleep disruption might be one way in which life events trigger episodes of bipolar disorders. Noting episodes are often preceded by life events interfering with ability to sleep. For example, trans-meridian flights, childbearing. This theory was developed more precisely by Ehlers in an elaborated model. Significant others serve the role of timekeepers. Social Zitbergs. Well, Zitbergs. This is a German word, so I cannot pronounce it properly. But these timekeepers, you have decreased need for sleep because of multiple reasons, and you may end up getting into a bipolar disorder. A job with the shift work hours. Sometimes you work at night, sometimes you work during the day. So the fluctuation in the job. So that is tricky as well. And that can lead to bipolar disorders. So, आओ चुप की जुबान में नासिर इतनी बातें करे कि थक जाएं. I'm not quiet. I'm talking too much. So, आओ चुप की जुबान में नासिर इतनी बातें करें कि थक जाएं. It's a beautiful, beautiful verse by Nasar Kazmi, of course, not me. आओ चुप की जुबान में नासिर इतनी बातें करें कि थक जाएं. Mood stabilizers and atypical antipsychotics. So the last bit, how to treat them. As I mentioned to you, first, as a psychiatrist, you have to assess all of these parameters that I have mentioned. The social model, the psychological model, the brain model, the genetic model, then the symptomatology, the trickiness in the symptomatology, and when you have a firm diagnosis with you, that this is the person who is suffering from bipolar 1 disorder, the treatment is definitely much easier than what it is expected. Treatment of mania, if I still say that lithium is the best option. But unfortunately, there are so many ifs and buts associated with lithium. Now, this is again a real lifetime situation that I'm quoting here, that lithium Long time back, when I started practicing, lithium was available in a tablet form by the name of Camcolit and Pridal. Those were the two forms available at that time in the market, brand names. They were excellent. And we used to give lithium to the people and they were responding very well. Then somehow or the other, because of the government policies, because of so many restrictions, the dollar price, because it's a cheap drug, very economical. It hardly costs less than 50 paisa, which is nothing. Even at that time, it was 1 rupee a tablet, which was not at all expensive. So 30 rupees per month, and the patient was okay. Imagine, so cheap. When somehow or the other, those two drugs were withdrawn because of the government policies, unfortunately. The imports were banned, those two drugs disappeared. There was a long gap in the treatment strategy for bipolar disorders. No psychiatrist in between for 20 years wrote lithium in Pakistan. Again, very surprising. Maybe some of them were still writing, but most of them not, because it was not available in the market. Then some of the local companies started manufacturing lithium. I never had a good experience with any local manufactured lithium drugs, but unfortunately, when I don't have an option, I still prescribe lithium. It's an excellent drug to treat bipolar and mania. Treatment of depression. Although standard antidepressants appear relatively effective in treating episodes of bipolar depression, when used in combination with mood stabilizers, they can induce mania, accelerate mood cycling 20 to 40% of the patient when administered without a mood stabilizer. So if you have to give them antidepressant because you feel that a depressive episode is so intense, always combine it with a mood stabilizer. And the best mood stabilizer still would be lithium. You can choose any one of them. There are so many much available in the market, but that is the best. The problem of medication is non-adherence. In mania, unfortunately, or bipolar disorder, people have to take the medication for a long period of time. 2 to 5 years is average. Maybe long, maybe less, but most of the time 2 to 5 years. Now, how much people are able to take the medications so regularly? That is tricky, and we have to consider that. So compliance, 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 compliance. 80% of my patients coming to my clinics in Pakistan, they have poor compliance. They got well, they left medication, they had a relapse, and then things were complicated. So focus on that, and there's lots of data available for the compliance issue. But to ensure the psychosocial intervention, we have to go for the psychological measures in stabilizing and ensuring compliance, and of course, making sure that they won't relapse. And those therapies, again, exam question, psychoeducation, group psychoeducation, individual psychoeducational approaches, family-based approaches, individual CBT, and interpersonal and social rhythm therapy. We will talk about all of these sometimes if we'll get the time, but thank you very much for listening to me. It was a lengthy presentation. I tried to express it to you as much confidently as possible, but maybe I was quoting some examples that could be challenged. So just get back to me so that I can clarify myself more elaborately. इश्क अगर खाक न कर दे तो खाक इश्क हुआ. इश्क अगर खाक न कर दे तो खाक इश्क हुआ. Thank you very much for listening to me. Any questions?
Sir, I have a question.
Go ahead.
Sir, you talked about lithium for the treatment of mania, right? But usually we don't give lithium in patients who present an acute mania. Now, my question is, why do we choose lithium if we already have antipsychotics and they show good results in patients? And if we do choose lithium, then what are the suitable candidates for lithium in patients with acute mania? I'm not talking about the role of lithium as a mood stabilizer. I'm currently asking you about the
Acute,
presentation of a patient with acute
acute.
mania.
Got your question. Beautiful question. Very bad answer. Again, if we have to use lithium as anti-manic agent, the serum lithium levels should be maintained on a higher levels. So they should be something around 0.8 to 1 or around a little bit more than 1 millimoles per liter. So the levels are high. If I have to attain those levels, I have to work very diligently, very carefully, very methodologically, in a sound way. This means that the patient should be coming to see me every week, and then I'll be adjusting the dosage of lithium to treat acute mania. Or maybe he's in a hospital situation. So a loading dose of lithium, getting the serum lithium levels monitored. In the meantime, in those 3 weeks, when there are acute symptoms of mania, he has to stay in an isolated, seclusive, observed inpatient unit. Acute mania, complicated situation, very hyper, and you want to treat him with lithium only, then the situation has to be like that. Inpatient facility, secure facility, monitored facility, where he won't be able to get aggressive and break things. He should remain isolated, observed on one-on-one basis. So closed circuit television, small rooms, protected rooms, and then I will push up the lithium, get the levels checked after 1 week, push up the lithium, get the levels checked at second week. By third week, lithium will be able to correct. Even if we give antipsychotic, we have to do the same. We give antipsychotic and we expect the results in 3 weeks. In this situation again, we'll give lithium and expect the results in 3 weeks. The only difference is the secured environment. In antipsychotic treatment as an outpatient, most of the teaching hospitals, they don't have the secure wards. They don't have the one-on-one observable facility where the patient can be isolated and kept for 3 weeks time till the time his lithium levels are stabilized and his manic symptoms go away. That is tricky. So my answer to your question is, well, yes, I understand and I agree that all atypical antipsychotics, some of them are considered to be very good anti-manic, antidepressive, and mood stabilizer properties. When I'll be teaching the treatment of, again, specific treatment for bipolar disorders, I will definitely go through that. It's another big topic, so we will definitely touch that. But if I have to use lithium only, I will admit my patient in close supervision, in secluded ward, which I made in Services Hospital. 2 of the rooms were explicitly made for this purpose. They were supposed to be padded with, again, fiber glass sheets with all the options in the toilets and the washrooms, which patient won't be able to disrupt or break or injure himself or the property. And my target was to make sure that I should try these treatment strategies which are theoretically proven and are worth it. But unfortunately, politics. So we lose the situation of having state-of-the-art setups for these kind of people. And once the patient is on lithium in an appropriate dosage, it will be anti-manic and antipsychotic and mood stabilizer, and the patient won't shift into the depressive phase as well. But that is tricky. So we don't follow that because of that reason, specific reason that I have mentioned to you. So we rely on antipsychotics, atypical antipsychotics, which act as a mood stabilizer as well. That is a shortcut. But There is evidence for that as well. Any other question? Okay.
Sir,
Yep.
sir, there are some questions in the chat box too.
Okay. Okay. Sorry, I never moved it down. What are the age limitations regarding beginning of lithium in bipolar disorders? Well, as far as I remember, I have seen the studies, and the lithium is prescribed to person who is even 9 years of age. So there is literature available, so it can be prescribed from any time between, again, early teenage to late 70s, but you have to monitor it. Really enjoying your example, sir. Oh, thank you very much, sir. Borderline personality disorders overlap with BAD a lot also. Well, borderline personality disorder not overlaps the bipolar disorder, but in borderline personality disorders, there are micropsychotic episodes which resembles the bipolar disorders. If a person is having a borderline personality disorder and bipolar disorder, oh, it's the end of the world. So it will be too difficult to manage. I haven't seen a person who's having bipolar disorder and borderline personality disorder. But if you say, I will look into it, how much is the literature and how much it says. Can cyclothymia be present in a person who seems apparently normal and remain undiagnosed throughout their entire life? Yes. Yes. Definitely. I can quote you examples that as well. But unfortunately, quoting those examples will complicate this presentation. I won't be able to upload this on the YouTube. So let me stop the recording and I will respond to those questions. Okay.